Module 3. It's Chapter 15, Medical Overview, and it's literally exactly what it sounds like. It's not necessarily fast paced, but it does go over what we're going to be expecting out of you and the things that you should be expecting to see coming in the next few weeks while we go over the medical module. And essentially, we're just going to apply basic knowledge to everything, but we're going to be using our assessment and we're going to find out our pathophysiology and how we're going to manage each one of these. We're going to talk about infectious diseases with awareness and even, let me go back, but assessment and management of, and then we're just going to go forward from there. You guys are going to, I think, be really excited over this particular one. Let me mute my phone real quick. Apologies, guys. All right, so patients who need EMS assistance generally have experienced a medical emergency, a trauma emergency, and sometimes even both. It's not out of the realm of possibilities to go to a car accident because someone has had a medical emergency, such as a seizure, a heart attack, a stroke, things of that nature. So you may be dealing with both kinds. Thankfully, National Registry gives us, for the most part, only one at a time. So don't get overly confused with those. So right now we're just dealing with medical, okay? And we're going to talk about respiratory emergencies and what we're going to do for them. Cardiovascular, same thing. Neuro and neurological emergencies, those obviously involve our brain, but that goes a little bit further too. GI conditions, there's a lot of those. There's over 400 different things that can be going wrong in the GI-GU system. And there's the urologic emergencies. Kidney stones is a big one that you're going to see in the field. Endocrine emergencies, and of course, the most complication, the most one that you're going to see for endocrine are going to be your diabetic emergencies. And then hematological emergencies, such as sickle cell and blood clotting disorders. Emergencies such as anaphylaxis, toxicology, you're going to see all of these. And then psychological and behavioral problems is a huge one. And we'll even dip off into gynecological emergencies. So you guys can look at your table 15-1, and that just goes over our overview for the night. Okay, so let's go back into patient assessment. Such a big deal. And remember, we discussed patient assessment goes in order for a reason. And that's so that I'm not going to leave anything out when I go and I talk to a patient. My first step is I'm gathering information as I'm going to the call. I'm going there and being safe. I'm doing all of those things. I pull up to the scene. I check for my safety. I check for all of those. Along with it, I'm going to continue to check for any life threats that may be pursuant to me. Hold on just a second, you guys. I've got a 8-year-old in here. Okay, so sorry about that, you guys. Okay, but as we're going to this call, once again, we're going to be safe. We're going to do all the things. When we get on scene, we're going to take our general precautions, and then we go from there. You got to worry about scene safety. You got to worry about, now we're going to go into nature of illness, symptoms, chief complaint. We're also going to worry about how to establish our accurate medical history. Yeah, you can look at a patient and tell, hey, they're pale, they're ashen, they're gray, they're all of these different things. But could it be because of a medication that they're taking? Could it be because of the history that they have? Another big thing to talk about is using your dispatch information to guide your initial response, and that's wonderful. Dispatchers get certain key pieces of information. Sometimes they don't get all the information. And then sometimes you get on scene and it's not even the information that they gave you. But what we do is, as we're going to these calls, we have our own response that we can think of in our heads. If we know that there's someone that's unresponsive, we already think all the way from maybe it's a diabetic emergency, a syncopal episode where someone just passed out, or it could be a cardiac arrest. And these are the things that we get ourselves ready for, if that makes sense. But also, we don't want to get tunnel vision when we only focus on that one small aspect of a patient's condition. So just don't get locked into that. An assessment may be difficult with your uncooperative or hostile patients. And guys, it's a big deal for those. But we have to be professional. We have to be calm and we have to be non-judgmental at the same time. And it says in here demeanor. I want you guys to understand a demeanor is your overall appearance and how you are reacting to things. I don't have my camera on because I'm sitting in the dark because I have a terrible headache, but I can deliver my mouth from evil, but I cannot deliver my face. And it is something that I've had to deal with for years and years. And I think I've finally gotten better at it. But when someone says something a little messed up, I might give them a little glance. And you don't want to do that. So if you're one of the people that are just like me, remember that about yourself. And you already know that about you. And always give everyone the benefit of the doubt, especially with uncooperative patients, because if it's a behavioral emergency, or it's a psychological emergency. Um, Thank you so much, Chris. I appreciate it. Let me see if I can make it to 7. I think I'm okay for right now. That pill has me a little wonky, but I'm okay. Pardon me. But just keep yourself trained in the way that you are going to be as professional as possible, okay? And refrain from labeling any patients and displaying any personal biases. Guys, it's 2024. No matter how you feel about certain things, we have a presidential election coming up this year. That's a big hot button topic. And you may go on a scene and the patient has the other guy's face plastered all over their home, and we can't show up and have an issue with that. And then of course we have our frequent callers, and they call all the time for a reason. So first thing that we're going to do is our scene size up, and we're going to make sure we're safe, standard precautions. How many people do I have? Do I need additional resources? And I'm going to check out my nature of illness, and that's going to be because it's medical. And I'm going to have a high index of suspicion on anyone when I first look at them. But my awareness of potentially serious underlying injuries or illnesses. So what does that mean? It means that when I first give an initial response and look at someone, I'm automatically going to the worst case scenario until proven otherwise. So if I need to go ahead and initiate spinal immobilization, I'm going to do it, even if it is nature of illness. If I feel like there's a traumatic something, that's what I'm going to do. Primary assessment, what's our general impression? Are they sick, not sick? Are these people stable, unstable? We're going to perform that rapid exam in 60 to 90 seconds, and then quickly determine what their LOC is. So remember, we're going to use AVPU. Are they alert to person, place, time, and event, or all the way to unconscious? Now we're going to go into our airway and breathing. Now remember, a conscious patient, if they can talk, then they have an open airway. And if they can talk, usually they have adequate breathing, right? But we're going to ensure that their airway continues to stay patent, check our respiratory rate, depth, and quality, and consider oxygen if necessary. And of course, always with our unconscious patients, we're going to make sure that we use whatever technique to open the airway properly. So if it's a patient that hasn't had any traumatic things happen, we're not worried about C-spine. We can roll them in the recovery position, right? We can put an OPA in someone that doesn't have a gag reflex. We're going to go over those later. But moving along, if we're going to apply
Hey, I'm
oxygen,
sorry to interrupt you, but I think I'm in the wrong lecture.
I didn't see you come in. So are you advanced?
Yes, ma'am.
Okay, Chris is having a patient right now, and he said that he's going to send you an email. Check your email for the video. It's a pre-recorded lecture, and he
Okay.
will. Yes, ma'am.
I came in late. I'm sorry.
No, you're fine. You're fine. It happens.
Have a good night.
You too. Pardon me. Okay. And also remember that they may need those airway adjuncts and even a bag valve mask. Okay. Circulation. If a conscious patient, go ahead and check that radial pulse, observe the patient's skin color, temp, and condition. And for unconscious patients, assess the circulation at the carotid artery. We always want to go straight to the carotid because we don't want to waste time with the radial artery. Okay. Transport decision. This one's pretty simple. Hey, are they serious? Let's go rapid. It's pretty simple. So what determines if it needs a rapid response? Okay, that's going to be unconscious, altered mentation, airway and breathing problems, circulation problems. Remember, we didn't really cover if there were any major bleeds in this particular one because it's a nature of illness, but that's way up there above the ABC. So if there were severe bleeding or signs of shock, obviously that's going to be a rapid transport. Now we go into our history. What's the problem? What's going on with this patient? What's causing it? And we're going to get our thorough history. And if obviously we have an unconscious patient, we're going to look for medication containers, medical devices, check for a necklace or a bracelet, check inside of their wallet if necessary, check their phone for in case of emergency. In iPhones, they have a place where you can put your medications and currently what's your medical history, medications, and even allergies. Even if you don't have any of that, then check with bystanders, okay? Because and family, friends, things of that nature. And we're going to do our sample in OPQRST and record our allergies, medical conditions, medications, obviously. And keep in mind that we do have something called polypharmacy, and that's many prescriptions. And you're going to find our elderly have polypharmacy. And so it's hard. Sometimes they will have a basket or a bag full of medications. So be wary for that. Now, our secondary assessment, this could occur on the scene or it could be in the back of the ambulance. Like it says on the slide, in some cases, you really may not have the time to go and do those things. That's okay if you don't have the time. If you're continually reassessing your patient because they have some big issues and you are readjusting everything you do, you're taking care of that patient, that's fine. Let's say that you do have time. What do? We do our physical exam. On all conscious patients should undergo a limited or detailed physical exam. And for our unconscious patients, we're always going to perform a secondary assessment of the entire body from head to toe. And that's, once again, I want to say the caveat is if you have time. If this is a patient who is unstable and continually being unstable, you will not have that time. Examine head, scalp, and face, neck, chest, abdomen, arms, and legs. And remember, when we're palpating the legs and the arms, you're going to do those at the exact same time. And you're going to log roll your patient and check their back. Let's do our vital signs. We've already checked our pulse, so we've already got something to go a basis off of, right? But we're going to recheck it again. Pulse is going to have your rate, quality, and regularity. And we're going to do the same thing for our respirations. And then, of course, blood pressure comes up. Consider getting your CBG or your capillary blood glucose level and pulse ox, as always. And you can go ahead and take these. Your initial blood pressure should be here, but if you should have already had a pulse rate and a respiratory rate during your initial ABCs. So you can take that as a trending. And then of course our reassessment. Okay, this is after we've done our assessment and treatment. I want you really guys to realize that. Reassess after the initial assessment and treatment. There's no sense in reassessing anybody if you haven't done anything for them, right? Remember, if this person is too bad and you need help, go ahead and consider for ALS backup. And if there are any interventions, and I want you to go down the same pathway that we do in our patient assessment, where you start at the head and you move all the way to the toes. So if you've put in an oral airway or a nasopharyngeal airway, you're going to check to make sure that's still patent. If you are breathing for this patient using a bag valve mask, you're going to ensure that you're getting a good, if you're doing any other kind of intervention, you're going to go back and reassess those, and then you're going to document as needed. Don't forget, we're going to go ahead and get our vital signs. Now, in the reassessment period, you have, if it's a patient that is unstable, we're going to do this every 5 minutes and 15 for every stable patient. So don't forget those during your reassessment. Okay, so management is transport and destination. So most medical emergencies require a level of treatment beyond that available in the pre-hospital setting. Obviously, they've got to go somewhere, right? So we want to make sure that they're going to the correct facility as we go. And we have levels of treatment. So some of them may require some advanced testing, like for strokes. And it may be beyond the it may also be beyond the scope of an EMT to administer certain medications to a patient. So you need to be wary of that. And any administration of a medication that has been given by an EMT does require direct permission from med control. So please be wary of that as well. And don't forget, you guys can use AEDs. Scene time. Hey, if you've got a medical patient and you really need to take care of them, yeah, sure, we can be on scene for a little bit longer. But remember, when we talked about trauma patients, we have our golden hour, so 10 minutes max on scene for them. But since we're in medical, let's gather as much info as we can. And once again, that goes to really interviewing your patient and finding out what's going on. Critical patients always need our rapid transport. Remember, we go back to those reasons why: altered mentation, ABC difficulties, and the very old and very young are also part of those. So we have our life-threatening condition, lights and sirens, transport, and then we have our non-life-threatening conditions, which is considered non-emergent transports. Those are just, you go straight to the hospital, you don't go lollygag around town, but essentially you're going to get them there, right? But then there's also another two categories. You have ground versus air. Depending on your local protocol, will depend on whether an EMT can call for a helicopter or not. So always check for those first. And ground units are generally staffed by EMTs and paramedics, and that is normal nationwide. And air transport EMS units are generally staffed by critical care transport professionals and paramedics. And so usually that's an RN and a paramedic. Destination selections, generally it is the closest hospital, but like I said, if you have a patient that needs stroke assessment and the nearest hospital does not have a CT scanner, you have to go that extra mile, literally, and take them to where they need to go. So just depending on what it is, make sure you know about your local protocols and your local hospitals. All right, let's talk about infectious disease. General assessment principle is approached like any other medical patient. And we're going to do all the same stuff, all the same guidelines, and we're really going to make sure and elaborate on the patient's chief complaint. We're not going to do anything out of the way here, right? We know that we need to protect ourselves. Obtain our sample history, baseline vitals, and we're also going to ask something very different here than we would in other cases. And I want you to pay special attention to this. Ask whether the patient has recently traveled or has come into contact with someone who has traveled. If anything, we have learned more about infectious disease with COVID, so this is nothing new. General management principles, we're going to focus on life-threatening conditions, and those are going to be obviously identified in our primary assessment. Remember, we're dealing with, at this point, we're still in NOI, which is nature of illness, right? So we're not really worried about major bleeds, but we're definitely worried about our ABCs. Where's our airway? Where's our breathing? All of that. So if there's a life-threatening condition, we've already identified it. Be empathetic. People get really scared when they get really sick. Be aware of how you react to patients. Place them in a position of comfort and keep them warm, and use our standard precautions as normal. Epidemic. I think we all know what the definition of epidemic and pandemic are now. Prior to COVID, a lot of people got those confused. I don't think they do anymore. But epidemic is just new cases in a human population, and a pandemic is a disease outbreak that is global. So the flu, it's serious. Don't know if y'all knew that or not. It kills a lot of people every year, especially when, and you can read here on this note, chronic medical conditions, COPD, CHF, compromised immune systems, people with cancer, very young, very old. They're the ones that are the ones that the flu really does damage to. Of course, we know that flu is transmitted by direct contact with nasal secretions and aerolized droplets from coughing and sneezing by infected people. Did you know that when you guys Hey, Christopher, you guys are going to get an email from Chris. He is not going to have class tonight. Instead, he is sending you guys an email with a recorded video. So go check your email, okay? I'm not sure why I'm not seeing you guys come in.
That's what I'm trying to sit here and watch.
Okay, thanks. You're so welcome, Christopher. You have a good night. Did you guys know that when you sneeze, that travels 100 miles an hour? It's disgusting when you think about it. So please cover your mouth. There's nothing worse than my 4-year-old sneezing and not covering her mouth at all. It's probably why we stay sick at our house. Okay, so for diseases that can be passed by the respiratory route, remember our PPE. But in this case, we're going to add a little bit more. And every single one of you guys have heard of a HEPA respirator or an N95 mask. But obviously, eye protection and gloves, because here's the deal. If they're coughing and they're sneezing everywhere and it gets in your eye, it's the same thing. So you want to protect your entire airway, your eyeballs, and of course, we want to protect our hands. So we're also at this point going to place a surgical mask on the patient with suspected or confirmed respiratory disease. I would definitely remember that, guys, because I know for a fact I've had that question on registry. And also be ready that even though you put these masks on these patients, please be aware that you still might have to suction their airway. Please be aware that you may still have to perform CPR. There are different things that can happen to that airway. So just because you're putting a mask on that patient doesn't mean that you don't go back and reassess their airway, okay? And then annual influenza immunizations is important. A lot of EMS personnel are either, I think in Mississippi, the way it works is it's not required in most places, but I know in several hospitals that if they do not take the flu shot, they have to wear a mask the entire time they're at work. So check your local protocols for those. But it's a really good idea to go ahead and have that. Herpes simplex. It is a common viral strain carried by humans, and there are symptomatic infections caused by eruptions of those tiny fluid-filled blisters called vesicles, and those appear on the lips or genitals. And yes, there are two different types. The ones that are on the genitals are just normally called herpes, but the ones on the lips are normally called fever blisters. So don't get overwhelmed when I say this, but that is a type of herpes simplex virus. They can absolutely cause more serious illness to other patients, especially like if they have pneumonia or meningitis, very old, very young. And so our primary mode of infection is through that very close personal contact. So be very careful. HIV, guys, everyone risks exposure to HIV. HIV, to be honest with you, isn't the scariest thing out there anymore. No vaccine as of now. AIDS is still fatal, but the treatment, guys, these people now in the 80s, it was a death sentence. Now these people are living much later in life, almost a normal lifespan. And you will see these people and they'll hand you their medications and they'll say, hey, I have HIV or I have AIDS. But there are some times when you'll get a note passed to you while you're on scene and it says, I have HIV, don't say anything. And you don't, because that's a HIPAA violation. Now, it's not easily transmitted in the work setting, but of course, you want to watch out for sharps of any kind, especially if you were assisting a paramedic or an advanced EMT. But for the most part, an EMT's risk is very low. HIV patients really don't show a whole lot of symptoms, but once again, we're always wearing our gloves, right? We don't get out of the truck with our gloves on. That's just not a thing. We got to take our PPE, right? Take great care in handling and disposing of those needles, like I said before, and cover open wounds. And do that with just a normal 4x4 and some tape or even some Curlex if necessary. And that's your roller gauze, by the way. And if you think that a patient's blood or secretions may have entered your system, go ahead and seek medical advice and notify your infectious disease officer. And depending on your local protocol, and these are things that you need to know while you're working for your people, okay? Wherever you work at, you need to know what that is. The last place that I worked, the protocol was that we immediately take the patient to the hospital, and then whatever hospital we go to, we are seen at that point from that hospital. And then we become a patient there, but we notify our supervisor. Others that I've worked for, they have said, if I believe that I have had, let's just say I get a needle prick, they say that I'm immediately to call the supervisor and wait for another unit to come get my patient so that I can go straight to the hospital at that point to become a patient. So it really depends on where you work. Hepatitis, this is scary. It is inflammation of the liver, and it can be caused by viruses and toxins. No way to tell because there's different kinds. So you just have to protect yourself. Hepatitis A transmitted from, they have the acute infection, whereas hepatitis B and C can be transmitted from long-term carriers. And they don't even show signs of illness sometimes. You have to think about that. Hepatitis A is normally transmitted orally, but it is also through oral and fecal contamination. Hepatitis B, much more contagious than HIV. Hepatitis B is the scary one. Remember, there are vaccines available for this, and they are definitely recommended for the EMT. They're recommended for anyone. And you guys can look at this table and make sure that you read over it about hepatitis. I'm going to move on to meningitis. Now, this is the inflammation of the meningeal coverings of the brain and spinal cord. And most forms of meningitis are not contagious, but there is one form in particular, the meningococcal meningitis, and it is highly contagious, to the point where they will put them in a closed off room, and they are quarantined from the remainder of the ER. Of course, we're going to take standard precautions, but gloves and masks, hey, we're going to go ahead and use the masks on these people, right? But this goes a long way to prevent the patient's secretions from getting into your nose and mouth. So remember, when we know that they have something that they can cough and sneeze and it get on us, we can put a mask on them. There is a vaccine, but it's rarely used. And after treating a patient with meningitis, contact your employer health representative because they need to know that. TB is so huge, and it's such a terrible chronic illness for the respiratory system. And if you have an active case, they will put you in a quarantine and handle you effectively. Mississippi has a lot of TB cases, but we keep it under wraps pretty well, because we have people, remember we talked about in earlier chapters that there are certain diseases that have to be told to the state, and TB is definitely one of them. Yes, Chris Wally, do you have a question?
Miss Sandy Miller, please check your direct message and your email, please.
Thank you so much. So most infected patients are well most of the time, and a chronic mycobacterial disease that usually strikes the lungs, and it does occur shortly after infection, called primary TB. And reactive TB is common and can be much more difficult to treat. So the patients who pose the highest risk, they're almost always going to have a cough. So what are we going to do at this point? We're going to consider that respiratory TB to be the only contagious form because it is the only one that is spread by airborne transmission. Remember, a droplet nuclei and the remnants of the droplets produced by coughing after excess water has evaporated, you can still get that, okay? So we're going to use our N95 or a HEPA mask, and that's required to stop droplet nuclei, okay? Absolute protection from this does not exist. 1/3 of the world's population is infected with TB. You go down to certain countries in Africa, and it's so widespread that it's actually harder to find someone without TB than it is the other way around. Entire villages and communities have TB. According to the CDC, that's where we're at. The mechanism of transmission, not very efficient. So what are we going to do? We're just going to go ahead and get our TB test every year, right? We're going to make sure we don't have this stuff. If the infection is found before you become ill, preventative therapy is almost 100% effective. So that's really good. Okay, whooping cough, also called pertussis, And that's an airborne disease caused by bacteria. And usually it only really affects children younger than 6 years. However, guess what, guys? We can carry this on us, and adults do get pertussis, but it's more likely that we'll have a day or two of just not feeling great, maybe have a cough, maybe not, and guess what? We have it and we're carrying it. So it's very important for us to understand that even though we don't feel like we're really that sick, we can still carry certain things. So one of the biggest symptoms here is fever and a whoop sound when that occurs after, or I'm sorry, when inhaling after a coughing attack. And it is uh, it's very specific. You can go online, check YouTube. I know for a fact in your boot camp, I don't want to call it boot camp, but in our setup, there are several different places where we have adventitious breath sounds and things of that nature. I'm not sure if whooping cough is in there. I'm gonna have to go check to see. But suffice to say, if you want to know what it sounds like, you're gonna hear it one time and you're gonna be like, hey, wait a minute, I have heard that before. The best way to prevent exposure is to be vaccinated and place a mask on the patient and yourself. MRSA is a bacteria that causes infections and it's resistant to a whole lot of antibiotics, hence why it's called methicillin-resistant Staphylococcus aureus. You're going to see MRSA transported or transmitted from patient to patient by healthcare providers with unwashed hands. Let me tell you, when they found this out in the hospital, and when you find out that you have MRSA because a nurse didn't or a doctor did not wash their hands appropriately, that's pretty bad. Factors that can increase the risk of MRSA are antibiotic therapy. And you're probably thinking, well, wait a minute, if they're already taking antibiotics, why not? Guess what? If you're already taking antibiotic therapy, then your immune system is already down. Along with, there's a lot of people that they'll take their antibiotic therapy and then they'll feel better 3 days into it or 4 days into it. And they're like, I don't need to take the rest of these antibiotics. I'll be fine. And they continue to do this over and over again. And guess what happens? They'll catch MRSA and then they have had a methicillin resistant strain. Okay. Now it can be from a stay in the ICU or a burn unit and get a lot of them from there. And exposure, obviously, to an infected patient is another one. And it's always from a soft tissue infection. Incubation period is between 5 to 45 days. And it looks like a localized skin abscess and even sepsis in older adults. All right, let's talk about our global health issues. COVID-19. Of course, we've heard so much about this and a lot. This is just a very small overview, but it's the 2019 novel coronavirus, and it originated in the Wuhan province of China. It was spread very quickly, killing hundreds of thousands. Of course, we dealt with it with social distancing, but of course, our symptoms are going to include the fever, cough, shortness of breath within 2 to 14 days of exposure. And as always, if you need to know more about that, go ahead and check out the CDC guidelines on the cdc.gov. MERS/CoV is the Middle Eastern Respiratory Syndrome coronavirus, and you will see that. But the first one was discovered in 2012 in Saudi Arabia. It is most human infections found in the Middle East, and some have been found in Europe and the United States, but not very many. But if you do suspect it, go ahead and cover that patient with a mask, okay? Ebola. I've only heard of one case of Ebola that came to the United States. I don't know what year. I know they came to the port of New Orleans, and that's pretty darn close to where I live, and it scared the life out of me. Ebola is bad. Incubation period. Oh no, Michael, no. You were actually there during no. See, that just made my skin crawl. I get upset with that because Ebola, you get it. You're just, oh, okay, sorry. I hope you have everything ready to go. Because the fatality rate is as high as 70%. So a lot of people do die from Ebola. But if you happen to see somebody that you think may have Ebola, your incubation period is between 6 to 12 days after exposure. And symptoms might not even appear for as long as 21 days after infection. Of course, I would, if I thought I had taken someone with Ebola anywhere, I would just promptly go to my ER and stay there for as long as it took. But if you do suspect it, go ahead and put that surgical mask over the patient and follow all PPE precautions and notify your CDC. Notify the facility that you're going to that you may be having somebody with Ebola. They're going to freak out at first, but it's okay. They're going to take care of it. Travel medicine. Be aware of travel acquired infections when assessing a patient who has recently been outside of the United States. That's why we're going to ask those questions with infectious diseases, right? Patients can present with a variety of symptoms, and you guys can go in and read those. But when you encounter someone that's ill from traveling, go ahead and put a mask on that patient and obviously get as much information as possible out of those people. Some of the most important questions to ask are right here. Where did you recently travel? Did you receive any vaccines prior to going? Were you exposed to anything? And is there anyone else in your travel party who might be sick? What types of food did you eat? And what is the source of your drinking water? So in conclusion, assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. The conditions of the medical patient may not be as apparent in a trauma patient, and treatment may not be as straightforward. And delays in an attempt to diagnose a condition can be very harmful to the patient. Keep calm, use your patient assessment skills, treat the patient's symptoms, report to med control, and transport the patient safely to the ED, and be prepared to handle any combination of conditions, including conditions of medical patients who have been involved in trauma. So let's do a review real quick, guys, and get out of here. There's 17 people here, so potentially there's an advanced person in our class. -2 would be myself and Chris. So I expect at least 10 people to start answering. So number 1, a seizure patient is having what kind of medical emergency? Respiratory, cardiovascular, neurologic, or immunologic? Keep them coming, guys. I got 5 people on the board. We need at least 5 more. And I may have a headache, but I don't have the light on, so I'm good. I'm good to go till 10 o'clock. We can sit here all night. That's an interesting sound to whoever just unmuted.
I don't know if it's muted or not. This thing is not working.
It is definitely not muted.
Okay, yeah, I'm gonna have to back out and then do it again. Wait a second.
Think you got it now?
I think. Can you hear me?
Yeah, I can hear you.
Oh my gosh.
I can still hear you. Go ahead and back out and get back in.
Okay.
Thank you. Did sound like a dog toy, Tammy. Okay, the correct answer is C. You guys were spot on that one, so very good. And of course, neurological emergencies involve the brain and may be caused by a seizure, stroke, or fainting, which is also known as syncope. All right, number 2, if an injury distracts an EMT from assessing a more serious underlying illness, the EMT has suffered from A, tunnel vision, B, index of suspicion, C, virulence, D, a trauma emergency. If an injury distracts an EMT from assessing a more serious underlying illness, the EMT has suffered from A, tunnel vision, B, index of suspicion, C, virulence, or a trauma emergency. Okay. So I have 1, 2, 3, 4, 5, 6. All right, you guys are pretty insistent that it's gonna be tunnel vision. Thanks, Chris. It's tunnel vision. Very good, guys. And obviously what we're going to do is we use everything that we get from dispatch as a guideline, but we don't want to have some sort of preconceived notion. When we go into one, as we move into, and I'm going to go ahead and tell you, I had a dispatcher give me the absolute wrong dispatch information. She said that there was a 6-month-old that was in cardiac arrest. And I didn't have a governor on my ambulance, and I broke every law that there was to break to get to that call, only to discover that it was a 68-year-old who had passed out. So what did I do? I did exactly that, even though it was not necessarily because of harming the patient. It could have harmed myself or my driver at the time. Okay, so number 3, if a frequent flyer calls 911 because of a suspected head injury, you should never A, take the call seriously. Don't waste your time or resource on such a caller. B, perform a primary assessment. He called for a head injury last week and it wasn't serious. C, assume you know what the problem is. Every case is different and you don't want to miss a potentially serious problem. Or D, treat the patient with respect. He's probably lying. Keep them coming, guys. I know there's more of you. Is the sound off for that? Will this work? All right. All right. Very good, guys. Oh, let me take that off. Answer is C. Good job. Obviously, we're not going to label patients. We're not going to be rude. We're never going to assume what's going on. That's terrible. Number 4, if your medical patient is not in critical condition, how long should you spend on scene? 10 minutes or less, 30 minutes, 2 hours, or however long it takes to gather as much information as possible. If your medical patient is not in critical condition, how long should you spend on scene? 10 minutes or less, 30 minutes, 2 hours, or however long it takes to gather as much information as possible. I'm going to wait on a few more to answer. All right, the answer is, of course, D. You guys are so good. I feel like I don't even need to be here. Obviously, we need to spend as much time as we need on those patient calls where we can and those patients are stable. Okay, number 5, your patient's having respiratory difficulty and is not responding to your treatment. What is the best method of transport? A, without lights and sirens to the closest hospital. B, with lights and sirens to the closest hospital. C, air transport to a specialty facility located 30 miles away. Or D, the patient does not need to be transported. What are you guys thinking? Looks good to me. B is the correct answer. You guys are on fire tonight. All right, your patient, sorry. Number 6, when assessing a patient with an infectious disease, what is the first action you should perform? A, scene size up and take standard precautions. B, obtain a sample history. C, hand the patient off to a paramedic. Or D, cover your mouth and nose with your hand. I know these are easy, but keep them coming, guys. All right, very good. The answer is A. I think it's funny that they say cover your own mouth and nose because that's wood, but with a mask, right? Oh, what happened here? Your patient believes he has hepatitis and is now exhibiting signs of cirrhosis of the liver. He most likely has which kind of hepatitis? A, B, C, or D? If you guys were paying attention to the slide, you already know the answer. Let's just pretend you didn't, and y'all are just really intelligent. Y'all already knew this because I just know y'all did because y'all are that smart. Okay, the correct answer is obviously C. So very good. Just go ahead and throw that in there. Number 8, your patient is complaining of fever, headache, stiffness of the neck, red blotches on his skin, and he is mostly likely have TB, hepatitis B, SARS, or meningitis. Okay, guys, fever, headache, stiffness of the neck, red blotches on the skin. Does he have TB, hepatitis B, SARS, or meningitis? Okay, very good. It is meningitis. What should you do if you are exposed to a patient who is found to have pulmonary TB? Get the BCG vaccine. B, get a tuberculin skin test. C, undergo serious therapy. Or D, no precautions need to be taken. You cannot run, Chris. That is not the correct answer. You know I have a headache, right? You're not supposed to make me laugh. Tammy, stop. You can't agree with him either. Chris, you're killing me. The correct answer is B. Obviously, if you were exposed, you definitely need to get a skin test to see. Okay, number 10, and this is the last one, and then we're going to go to bed. I say go to bed. I'm going to go to bed. All the following are factors that increase the risk of developing MRSA, except A, antibiotic therapy, B, prolonged hospital stays, C, exposure to an infected patient, or D, close contact with wild birds. Come on, guys, make me proud. Let's go home with 100%. Come on now, I know there's a couple more of y'all in here. All right, I'm gonna go with D as the correct answer. You guys did really well tonight. Okay, so I'm gonna go ahead and stop the recording. Give me just a second.